Hello, everyone. Thanks for joining. We'll get started here in about 1 minute. While you're waiting, if you did not get a chance to fill out the pre-event survey that was emailed out this morning, we've dropped a link to it in the chat, and we would love if you guys would just take a few minutes. I think it's only about 4 questions to just please complete that if you have the time. And it looks like we are at noon, so we can go ahead and get started today. So on behalf of the American Heart Association, I would like to welcome you to today's webinar, Advanced Heart Failure in the U.S., Current Therapies, Clinical Gaps, and Access Challenges. My name is Kelsey McCauley, and I'm a program consultant at the American Heart Association. Today's educational content is made part and possible by a grant from Abbott. I'd like to begin today by going over a few items so you know how to participate in today's event. If you'd like a copy of today's presentation, you can download a PDF from the handout section of your attendance control panel. If you experience technical difficulties, most users can resolve these issues by refreshing your browser. If that doesn't work, please review the system requirements or contact GoToWebinar customer service team using the system requirements link found in the confirmation and reminder emails. At the conclusion of today's presentation, you'll receive a link to access the recording. We welcome you to submit text questions for our presenter at any time in the questions pane of the control panel. We'll collect your questions and address them during the Q&A at the end. I would also like to ask that if you did not get a chance to complete the 4-question pre-event survey sent by email this morning, to please click the link in the chat and complete this. We'd really appreciate it as it helps us to gain an understanding of knowledge gaps as we develop future education. You'll also be prompted with a post-event survey at the conclusion of our event.
Kelsey?
Yes.
So sorry to interrupt you. On my end, it's showing that the broadcast hasn't started yet.
Oh.
That the attendees are in mute.
Can anyone in the chat speak to that? Kristen said she did start the broadcast.
I am happy to hit start broadcast on my end.
Sure.
Brooke said it is showing on her end. I will also hit start broadcast, Kelsey, just so we have all our bases covered, and you might just want to start.
Here, people are saying that they can hear us, so I think we're good.
Okay.
Yep. Sorry about that. Thank you all for confirming that you can hear us. And are you still able to see my screen as well?
I don't see your slides, Kelsey.
Okay.
They're up now.
The correct side. Okay, thank you. Sorry for that. I think the start and stop of the broadcast may have disconnected it. We'll continue then. As a reminder, like I said, please complete the pre and post surveys if you get a chance. I'd also like to note that the recommendations presented today may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA-ASA. The AHA-ASA does not endorse any product or device. The webinar presented today is part of our Heart Failure Education Initiative, which is a 3-year initiative supported by Abbott that aligns with the rising need for advanced treatment pathways beyond traditional guideline-directed medical therapy for patients with advanced heart failure. Throughout this initiative, we'll be developing a series of educational events on this topic with the help of our 15 participating hospitals who are engaging in process mapping and learning collaboratives to share successful models of pathways and uncover barriers along the way. To learn more about this initiative, you can scan the QR code to stay up to date of our future educational opportunities. I'd also like to just remind you that one of the next opportunities that we'll be hosting as part of this initiative will be on Friday, June 27th from 1 to 4 p.m. Central Time, where we'll dive into available therapies for advanced heart failure patients, the importance of timely referrals, and share unique strategies for improving access to advanced heart failure care for patients in rural areas and those with substance use disorders. You can also scan the QR code here to register for this free event, and we encourage you to do so. We'll now move on to the presentation for today. We're thrilled to have Dr. DeVory of Baptist Memorial Hospital, Memphis here to kick off this educational series. Dr. DeVory is an advanced heart failure and transplant cardiologist at Baptist Memorial Hospital in Memphis and part of the Stern Cardiovascular Foundation, where he specializes in the care of critical or complex cardiovascular patients. He completed his internal medicine residency at Providence Hospital, followed by critical care medicine fellowship at the Cleveland Clinic, cardiology fellowship at the University of Illinois OSF St. Francis, and advanced heart failure and transplant cardiology fellowship at the Medical College of Wisconsin. Dr. DeVory's clinical interests include hemodynamics and heart-lung interaction. And with that, I will turn it over to Dr. DeVory to continue with the presentation.
Thank you for the kind introduction. Again, I go by Raj. So today's topic is advanced heart failure in the USA, current therapies, clinical gaps, and access challenges. So the objectives of today's discussion is identifying medical and social barriers in the treatment of heart failure, review potential existing solutions for the barrier, and ongoing work on future solutions for the barriers. I don't have any financial disclosure, although it's not included in the slides. I just wanted to describe that. So I'll just start the discussion by understanding what is heart failure. The heart failure is a clinical syndrome with a wide variety of etiologies and pathophysiology, which leads to either signs or symptoms due to structural or functional abnormality that leads to either reduced ejection or increased filling pressure. That's the definition of heart failure. And when I was getting trained for heart failure, it took me some time that this definition, although is simple, it's quite comprehensive. And every time I see a patient, and if there is a doubt in my mind, I ask myself these three questions like, does he have any signs or symptoms, structural functional abnormality, and does he have any problems with the ejection or filling pressure? And what is advanced heart failure is you just add few of the following things. Number one, severe and persistent symptoms, and additional 5 F words. The 5 F words are limitation in functional capacity, either assessed by NYHA class, 6-minute walk distance, or by peak oxygen consumption, peak VO2, as a part of the cardiopulmonary stress test. There is a significant fluid retention and high doses of diuretics. Frailty, that is because of either cardiac or non-cardiac etiology. Frequent hospitalization and end organ function that is abnormal. So that's how I tell myself if someone has an advanced heart failure physiology going on at this time. Now, the key, once you have identified a patient with advanced heart failure, is the intervention has to be done before there is irreversible pulmonary hypertension, irreversible end organ damage, or irreversible frailty, after which majority of the treatments are either ineffective or it's too late. Now, heart failure, again, because it's a, looks like thank you for whoever helped me with that. So heart failure, although is a name of a diagnosis, we have all experienced that it is extremely heterogeneous. On the left side of the screen, there is patient heterogeneity described in patients with HFrEF. On the right side, there are patients with HFpEF or heart failure with preserved ejection fraction. Not everyone is similar. There is not one medicine that will fit all. So when we are treating with the medical background, we have to personalize our choices of guideline-directed medical therapy. For example, in patients who have heart failure with reduced ejection fraction, AFib, and low blood pressure, sometimes we have to prioritize digoxin over something like ARNI or something like ACE inhibitor. Whereas sometimes patients who have normal blood pressure and normal heart rate, we can keep on going with the highest dose of ARNI or add hydralazine and isosorbate dinitrate. In other words, the prioritization of the medicines can be affected by underlying physiological changes like blood pressure, heart rhythm abnormality, renal limitation, and all those problems. So that's just medical heterogeneity in patients who have HFrEF. At the same time, patients who have heart failure with preserved ejection fraction, they may have different kind of heterogeneous cardiovascular comorbidity that can differentiate or create more heterogeneity. For example, one individual may have obesity, the other individual may have problems with arterial stiffening. Some other patients may have pulmonary vascular disease that may be coexisting with HFpEF. So in other words, there is no one medicine that will fix all kind of either heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. What we do know is that patients with majority of heart failure with preserved ejection fraction, most of the time, basic drugs like diuretics and SGLT2 inhibitor are quite likely applicable to most of them. And beyond heterogeneity, one of the most common tools that is either used in clinical practice or in clinical research is NYHA. But we all know that NYHA, as described by one practitioner, may not be same when compared to NYHA for the same patient by some other practitioner. One physician may say that it's NYHA class 2, the other physician may end up saying this is NYHA class 3. And there are several studies that have demonstrated that when NYHA, New York Heart Association classification, is compared with something like Euroqual 5 differentiating factor, 5 discriminant factor, Euroqual 5D, or Kansas City Cardiomyopathy Questionnaire, they don't match up. And the Kansas City Cardiomyopathy Questionnaire, it's a little bit longer, cumbersome, and Euroqual 5 discriminant scoring system is also not omniprevalent, and something like NYHA is so simple, it's used more common. But we know that NYHA, practitioner to practitioner, there is a lot of variability. This is also evident through several clinical trials, 4 clinical trials that have compared the treatment outcomes of NYHA class 2 and class 3. When the disease process is either in extreme, like NYHA class 1, or NYHA class 4. So when the patient is doing reasonably well or is too sick, they tend to match. But someone who has NYHA class 2 or class 3, that's where diagnostic or heterogeneity comes in. And their evolution based on the treatment is also different in different clinical trials. So that way we see that the NYHA has its own issues. And this is the reason over several past years, we have come up with different types of classification to identify a smaller subgroup of patients who need more care, more attention, and speedy referral. The ACC-AHA has stages, we all know, A, B, C, D. Once it moves from A to B, B to C, C to D, it stays there. Whereas NYHA classes, they tend to move from 1 to 4, depending on whether or not patient is doing well. Once a patient is labeled NYHA class 3, I encourage all of my participants today to start thinking of Intermax profile. Although this is a little bit less practiced, but it is not as complex as Kansas City Cardiomyopathy Questionnaire or Euroqual 5 discriminant. Basically, Patients who are NYHA class 4, they also match with profile 4, NYHA 4 and profile 4, they have resting symptoms. Profile 3 are inotrope dependent, and profile 1 is critical cardiogenic shock, who are either on ECMO or some high mechanical circulatory support, really sick. And profile 2 is in between them. Going back to profile 4, easy way of remembering is that they are bed bound or resting symptoms. Profile 5 are housebound. They can move around, but not too far. Profile 6 is street bound, someone who can go out, go to the mailbox and come back, or NYHA, or profile 7 is slightly less sicker than that. So this is an easy way of knowing or differentiating patients within the NYHA class 3 and 4, because those are the typically sicker patients. Next slide. Several guidelines have now been published about what should be the treatment plan for patients who have congestive heart failure. While we are working to find out what caused the congestive heart failure, possibly ischemic symptoms, valvular heart disease, heart rhythm, while those are being treated, patients should be placed on what is called the optimal medical management, OMM, or guideline-directed medical therapy, or GDMT. If those medicines work and they make the patients less sick or brought to NYHA class 2, then we can stay there. Or if they stay NYHA class 3, that's when we tend to upgrade the treatment to either cardiac resynchronization therapy based on their QRS complex width and ejection fraction. If they are candidates for mitral valve intervention, they get appropriate referral for the transcatheter therapy. If they need treatment change from ACE inhibitors to ARNI, that can be done too. Or if the treatment is inadequate and patients advance to hypoperfused state, or they have progressive end organ damage, or if they are in cardiogenic shock, they are referred to advanced heart failure centers, after which they are either worked up to get heart transplant or LVAD evaluation, or they end up getting palliative care referral. There are certain smaller group of patients who can be on palliative inotrope therapy. So this is just a vague pathway or vague map of how heart failure treatment is guided from different levels of illnesses of patients. Currently, the 4 pillars of heart failure with reduced ejection fraction, it's well known worldwide, but at least till 2 or 3 years ago, there has been a lot of therapeutic inertia. For example, ARNI, which has been available, FDA approved since 2015, it showed 31% mortality benefit over ACE inhibitors. But real world use till 2018, as shown in CHAMP-HF trial, was only 18%. I know for sure the percentage used in the community has increased, but I still suspect that there is still scope of improvement. Similarly, for beta blockers, the adherence gap is about 40% of eligible patients. They are not getting the beta blockers, as described in Get with the Guideline Heart Failure. Similarly, for SGLT2 inhibitors, there is a lot of scope of missed treatment. The SGLT2 inhibitors has shown about 25% reduction in hospitalization. MRA, such as spironolactone or eplerenone, has also been shown to cause 30% reduction, but again, it's one of the least penetrated medicine among the guideline-directed medical therapy 4 pillars. Going back one slide. As we can see, real world adherence, for some reason the slides keep moving back and forth. I'll go back here. The real world adherence is listed here. The reasons for non-adherence has been either cost, perceived side effects or real side effects, access because of financial issues, and other reasons. But the most common factor has been the cost. This slide is actually a reflection of VA practices and frequency of use of different kind of guideline-directed medical therapies. As you can see that patients VA, their use of SGLT2 inhibitors shown in the lowermost map of America and right upper map showing the use of ARNI or sacubitril valsartan is in red, which means very less use. Similarly, the patients who have advanced heart failure, stage D heart failure, which is about 300,000 at least, and by some measures it's close to 1 million, depending on different definitions used. The disparity of use in the medicines, 4 pillars of guideline-directed medical therapy is huge, especially among Blacks versus the white patients. Going back to the older data, that less than 20% of eligible heart failure with reduced ejection fraction patients were on quadruple therapy. That's the data from CHAMP-HF, so a little bit old, but I do believe that the data is better, but maybe not up to the mark where we want it to be. Of course, it is sad when zip code beats the genetic code. When socioeconomic strata, when it is classified into quartiles, as in the lowest earning group versus the highest earning group, when we see there is a stark difference in mortality, 54% mortality in lowest quartile versus 38% mortality. There's a difference in adherence to guideline-directed medical therapy, and there is difference in LVAD access, either late referral or lack of referral. So the driving factors in patients who are social economically deprived are actually several. It could be transportation barriers. Patients who live about 30 miles or higher, or they live in rural areas, they have difficulty in getting to the heart failure clinic. Similarly, patients who have food insecurity are less likely to take the guideline-directed medical therapy and will prioritize food, and can't blame them. There is also systemic bias. Patients who have lower income and they live in lower income neighborhood, and sometimes they cannot show up to the clinic. Majority of electronic medical system will have something called as a no-show rate. They can sometimes be flagged as who are considered non-adherent. So it has to be identified, and there are some proven level of interventions. At clinical levels, there is SNAP enrollment, which is a supplemental nutritional assessment program, which is available through the country. It has been shown to cause 30% decrease in heart failure admission when paired with guideline-directed medical therapy. Mail order medications, it also decreases transportation barrier, and it increases the adherence by about 40%. What can also be done at policy level or advocacy is a CMS heart failure hub model, and fund the clinic in food deserts. So the areas which can be identified as food desert, they are more likely to have problems with access to the heart failure care. In addition to the socioeconomic status, there is discrepancy in gender-based missed or misdiagnosis. This is mainly because, especially in women, they are more likely to present symptoms which may not be easily attributed to heart. They may have symptoms like fatigue or depression instead of chest pain. There may also be bias in testing. For example, there is about 30% lower stress echocardiography done in women. This often leads to delayed diagnosis. For example, 16% versus 16.5 months versus 9.2 months for diagnosis of heart failure. Guideline-directed medical therapy at target doses are lower in women. Same with referral for advanced heart failure therapy like LVAD. And this is the reason why in echocardiogram, women tend to have more heart failure with preserved ejection fraction, and their referrals are usually less frequent because oftentimes clinicians attribute severity of heart failure to ejection fraction, whereas patients can be equally sick when compared from their functional status standpoint, regardless of the ejection fraction. So what are the potential solutions? Potential solutions are bias training and frequent screening of patients who have elevated pro-BNP and electronic health records. They can have different kind of alert mechanism which can show women who have elevated pro-BNP. Women who have heart failure with preserved ejection fraction, the first-line SGLT2 inhibitor has shown to cause improvement in their heart failure outcomes. And patients who have pregnancy-associated heart failure or peripartum cardiomyopathy, they need to be screened closer with pro-BNP and markers because the sudden cardiac death in those patients have been known to be much higher. Alcohol-associated cardiomyopathy is known to be more common in men, and there is about 12 times higher risk in men when they are using alcohol. Next slide. Again, I'm glad that this is becoming more known, at least in the medical community, that how structural racism shapes the heart failure outcome. We know that patients of different ethnicity and they have different kind of access to advanced heart failure therapy. The example here shown is the Black patients have higher 1-year mortality compared to white patients. The LVAD access is significantly lower, and GDMT at guideline-directed medical therapy at highest dose is much less prevalent in patients of Black race. We also know that the general location of African American or Black majority, they are at zip code or geographic areas which have less heart failure specialists available. Just till few years back, most of the electronic medical records, they would show that creatinine clearance would be calculated by different measures. It has just been taken care of, at least in my organization, that the creatinine clearance, which actually determines qualification for certain medications, they have been just made similar for all races. It used to be different for patients with African American ethnicity. Similarly, what can be done at the bedside is a standardized referral pattern and a standardized way of prescribing guideline-directed medical therapy when they don't have any kind of contraindications. Some real hardware intervention can be in an electronic health records. We can have a hard stop for patients who are eligible for guideline-directed medical therapy. This has been actually shown to improve use of ARNI in Black patients. And again, at policy level, we can have certain policies that we can identify underserved areas and incentivize heart failure providers in those locations. Cognitive decline is another barrier in patients who have advanced heart failure. We know that about 40 to 60% of patients with advanced heart failure have cognitive impairment. This is a huge prevalence. And association of cognitive impairment has higher mortality and higher hospitalization risk. If you have mini mental status examination or Montreal cognitive assessment done in most of the heart failure patients who are above the age of 60 years, you'll be surprised as to how many of them have significant cognitive decline. The mechanism oversimplified is actually just hypoperfusion. Low cardiac output state causes atrophy of the white matter, but there are also many nuanced microscopic changes that happens, such as higher inflammatory markers that causes progressive neurodegeneration. Now, what can be done for this is actually screen for patients who have low ejection fraction, screen for patients who have older age, and certain interventions have been shown to cause slowing of cognitive decline. For example, guideline-directed medical therapy. Here I have mentioned only SGLT2 inhibitor, but actually it's all components of guideline-directed medical therapy, which increases the cerebral perfusion, brain perfusion, and should reduce the cognitive decline. Cardiac rehab referral has also shown to improve Montreal cognitive assessment score by a few points. Although the improvement are small, but it is still extremely helpful if we can identify and intervene in a timely fashion. Depression, again, is extremely common. The Hamilton Depression Rating Scale is considered the gold standard, and patients who have heart failure symptoms, they may also have depression, and their symptoms can be quite vague: fatigue, insomnia, and if you don't screen them, we won't recognize this. Beck's depression inventory is another way of identifying, but doing all these things in basic clinical practice can be difficult. What we know, if we intervene in such patients who have low Hamilton Depression Rating Scale, that there is significant improvement with prescription of sertraline or escitalopram, and a lot of patients have improvement in their depression score or Beck's depression inventory score. This has been proven. While we are taking care of patients with heart failure, one thing that can be easily ignored is hunger, and basically it's very much similar to the socioeconomic status. Unfortunately, despite America being a developed country, this is still a problem. 25 to 40% of heart failure have food insecurity, and this can be easily screened with a two-question tool. In the past 12 months, did you worry about food would run out? Did you have difficulty in getting food? And if any one of these questions is yes, then they are screened in for that. So what can be done for the patients is SNAP, or Supplemental Nutritional Assessment Program. And this in turn has been shown to decrease heart failure hospitalization by about 30%. Additionally, we can screen the patients for the food deprivation, and only 56% of the heart failure patients were eligible for participation, even if we screened them. So the remaining patients, they may not be supported by the Supplemental Nutritional Assessment Program, and those are the patients who may not be adequately covered by any government programs. So that is one of the gaps. Of course, financial burden, this is a known thing. 25% of heart failure patients struggle to afford medications. 20% of the patients skip medicine just due to cost, and out-of-pocket barrier increase the hospitalization risk. This is a well-known thing. I think all of us have experienced this while taking care of our patients. Now, when talking about patients who may be living with partners who have experienced violence with their immediate partner, I think that is something that should be screened also. Integrating HARC. HARC stands for, has your partner humiliated you? Are you afraid of your partner? Has there been a risk of rape? Has he ever kicked you? These kind of questions, like forced sexual activity, physical harms, any of this screen, when it is yes, then we should have social worker integrated in our practice and take care of them with the resources that we can have. The resources are National DV hotline, and heart failure specific, there are shelter referrals with medication refrigerations. When we use certain documentation like Z91.4, that can support our billing process for the care of the patients. And this has been incentivized by the government so that we can identify patients who have immediate partner violence. And why heart failure clinics must act is immediate partner violence, or IPV, has double one-year mortality in patients who have heart failure. And in 38 states, it's a legal duty by the care providers to report this. And of course, the literacy or healthcare literacy is also a silent barrier. 36% of our heart failure patients have less than 6th grade health literacy. And as a consequence of which, there is about 3 times higher medications error, and there is 50% lower LVAD consent comprehension. The SHLS stands for Short Assessment of Health Literacy. If this can be integrated in heart failure clinic, that can really identify patients' health literacy level. Certain easy treatment is using pill card for color-coded guideline-directed medical therapy charts, teach-back technique, or simply asking the patients about, hey, can you show me how you would take your Lasix on a busy day? that can take care of a lot of health literacy issues. The health literacy issue can also be integrated into the electronic health record, and it can flag the low literacy patients for extended visit. Instead of seeing them for 15-20 minutes, they can probably be seen for 30-45 minutes. And the staff can also be trained to avoid medical jargons, such as using the word water pill instead of a diuretic. The outcomes with intervention, the Michigan model, there has been about 40% decreased readmission using pictogram-based education. Going to the next slides. If not immediate partner violence, if a patient doesn't have any partner, that is also a problem. The loneliness. About 42% of advanced heart failure patients are socially isolated, either just them, or even if they have a spouse living with them, they may not have the spousal ability to take care of the patient, or their immediate children may not be available to take care of them. So they do deal with loneliness. And as a result of which, there is about 2.1% higher one-year mortality in patients who have social isolation. They also have 3 times higher missed doses of guideline-directed medical therapy. So what can be done for this is, for patients who have higher isolation, which is measured by certain risk scoring like PROMIS, the medication can be delivered to them with partner with mail order pharmacies, or have facilities like Lyft or Uber healthcare vouchers. This can be available under CMS transportation codes. For low home care support, sometimes heart failure specific home health support like frequent home nurse visit can also decrease the hospital readmission. There are other community programs like Heart Failure Buddies that has been shown to improve the social isolation. So this was just the difficulties that clinicians experience when taking care of the basic first-line therapies of heart failure. Now, when taking care of patients with advanced heart failure, oftentimes we use the second-line therapies, and the barriers simply increase. The second-line device therapies are often perceived experimental by third-party payers, and the result is delay in service provision. The prior authorization sometimes takes a really long time. Oftentimes it gets denied, and by the time we do use it, the patient's underlying heart failure conditions have progressed or has gotten worse. The second-line device therapies are something like a pressure sensor device. Some of them approved by the FDA, some of them are in pipeline. Even if they get approved or they are utilized in our clinic practice, what we often notice is the same barriers that we have seen in the first-line therapies, they apply here, and what happens is they don't use the devices appropriately, and over time, the adherence with the pulmonary artery sensor device gets lower and lower with time. What we know that there are many newer structural intervention that has been shown to improve patients with heart failure because of the valve disease, such as transcatheter aortic valve replacement, or commonly known TAVR, transcatheter mitral valve intervention, and now becoming more and more prevalent is transcatheter tricuspid valve repair. All the valve intervention, they have been clinically shown to improve, but they have also recommended majority of time to use services from specialized heart failure clinic so that they can be optimized. And this is a barrier if the heart failure providers are not available easily. Newer device therapies also include something called as cardiac contractility modulator and baroactive therapy. The cardiac contractility modulation, the device shown on the right side of the screen, is a pacemaker-like device with a couple of leads going to the right ventricular septum and activating in the refractory period. The device has been shown to improve the functional capacity as evident by peak VO2 and also their NYHA class. the device has unfortunately not yet shown to improve mortality. Very similarly, the baroactive therapy or vagus nerve stimulator, this has also shown to improve exercise capacity, quality of life, and some biomarkers of heart failure severity. There is some thought that it can decrease the hospitalization rate, but it has not been yet shown to decrease mortality. Hopefully, when the devices are used more commonly and we get access to them with a bigger patient sample, maybe we'll be able to notice that there is a mortality benefit. But as of yet, it has not been shown to cause mortality benefit. On the other hand, transcatheter therapy for aortic valve disease and mitral valve disease, they have shown to improve mortality. Certain therapies which are electrophysiological or done by the EP specialist are pacing of the AV node or His bundle pacing or conduction system pacing. They are novel and they work very similar to cardiac resynchronization.